Hello everyone, I'm Dr. Bhargavi and today we'll journey through the science and art of assessing hearing. This seminar will introduce both traditional and as well as modern techniques from bedside tuning folk tests to sophisticated tools like BERA and ASSR. My aim is to not just explain the methods but also help you understand why and how we use them, building a logical clinical picture in each scenario. So let's start. Let's begin with PTA. Now, which is the gold standard of hearing evaluation. So we test hearing using pure tones in PTA, which are single frequency sounds. So there are two parts: air conduction, wherein sound is presented near the ear canal to assess the entire hearing pathway, and bone conduction, wherein sound is sent via a vibrator on the placed on the mastoid process to bypass the outer and middle ear and directly stimulate the cochlea. If both pathways show similar threshold and the hearing is impaired, it suggests a sensory neural problem. But if air conduction is worse than bone conduction, it hints at a conductive loss. So let's go to the next slide. Now we go towards the checklist for PTA. Before the test, let's ensure the essentials. What are the essentials? The audiometer. That has to be calibrated, means the measurements have to be accurate. The patient understands the task, that is also important. So the communication is important. The patient should be placed in a room that is quiet. Then hygiene should be maintained, especially post COVID. As we know, the hygiene standards must should be improved. Seat the patient comfortably, give clear instructions, and begin with familiar sounds to build trust and reduce the anxiety of the patient. So these are the checklist before starting the PTA. Now, what are the factors that affect PTA? So, there are several variables that can influence PTA results. Loud noise exposure, such as loud noise exposure just before the test. Then there may be wax in the ear canal. Then tinnitus, language and communication barriers. For example, the patient cannot understand what language you are talking to the patient. A restless or a tired patient may also may not understand what you instructions you will be giving. Even minor issues like background noise or unclear instructions can change the results. So always double check the environment and prepare the patient. Okay. Now, when it comes to hearing sensitivity, our ears are more sensitive to sounds between 2000 to 5000 hertz, which is also the frequency of human speech. So, how like the speech that is I'm talking lies between 2000 to 5000 hertz. PTA typically tests frequencies between 250 hertz to 8000 hertz. The test should ideally last about 20 minutes. If it goes longer, fatigue can affect results. So give breaks to the patient. Results, as we know, results are plotted on an audiogram. Now the x-axis of the audiogram has frequency and hearing level is indicated on the y-axis in decibels. Now, we come to tuning fork test. Though they seem basic, tuning fork tests remain powerful tools for quick differentiation between conductive and sensory neural hearing loss. If you have to choose between PTA and TFTs, it was asked by my professor if whether you have to choose, if we have to choose between PTA and TFTs, you should always go for PTA, because in you should always go for TFTs, because in PTA there may be an issue like the machine may not be calibrated, audiometer, if the calibration is not good, then that can give wrong results. But in TFT, in these tuning fork tests, these are always and always they are very much correct in their responses, in their results. So we use Rini test, which compares air conduction and bone conduction, Weber test that helps to identify the lateralization of the hearing loss, and the absolute bone conduction, which is used less often now. But these tests are very helpful in emergency settings or where audiometry isn't available. So this is how our audiologist is performing the tuning fork test on the patient. As you can see, the Weber's is being done. Yeah. Now, use of these audiological tests. These tests are not just for diagnosing hearing loss, they help in determining the degree of hearing loss. Identify the type, whether it's conductive, sensory neural, or mixed. Prescribing hearing aids appropriately. Keeping medical records for follow up or legal needs. And even for medical legal evaluations like calculating hearing handicap percentages. So, understanding and documenting these tests accurately is very much vital. So audiometer settings and protocol. How should you go? When you begin PTA, you start at 1000 Hz, the frequency most easily heard. If the patient is likely normal, start at 30 decibels. For someone with hearing loss, start at 70 decibel to ensure they hear the initial tone. Each tone should last for, mind you, each tone should last for 1 to 2 seconds, and the ideal presentation is between 1 to 5 seconds, not too fast and not too slow. So this is PTA being performed. As you can see, the procedure is being performed here. The golden rule is 10 down, 5 up. If the patient comes to you, the patient hears the tone, you lower it by 10 decibel. If they don't, increase it by 5 decibel until the threshold is found. So you can get the threshold of around that 5 decibel range. Always test the better ear first. You should be testing the better ear first. Start with the air conduction followed by bone. If air conduction and bone conduction, the thresholds are the same and there is hearing loss, it's likely sensory neural. So in sensory neural hearing loss, both the air conduction as well as the bone conduction is affected. Sorry. Yeah. Now, what is the what is the exact procedure? So yeah. So when we look at the procedure, we start with 30 decibel for a normal patient, and if the response is present, we go to step 5. What is step 5? In each step, we go to step 5. That is when the response is present. That is decrease the sound by 10 decibel. Again, in step 5, we lower the sound by 10 decibel. Again, if the response is present, we repeat step 5. That is decrease the sound by 10 decibel. If the response is absent, we proceed to step 6. Now, we were at step 1. If the response is absent, we proceed to step 2. That is, step 2 is raised by 20 decibel. We initially raise more. 30, we go from 30, we go to 50. From 50, we go to 60. We check whether the response is present or absent, and if the response is absent, we go to the next step. Again, increase by 10 decibels from 30 to 50 to 60 to 70 to 80 in step 5. And if the response is absent, we go to step 6 and raise the sound by 5 decibel, that is around 85-90. And if the response is present, we proceed to step 7. If the response is absent, we return to step 6, that is increase by 5 decibel till the response is present. And if when we finally get the response, we in step 7, so 6 stimuli, so we at the end we finally get a response at some decibels. So at that decibel itself, we present 6 stimuli at the same level. If the 3 responses are correct, we record as hearing threshold for that particular frequency. If the responses are less than 3, we again we again go to return to step 6. What was step 6? Yeah. So again, now PTA reporting. How is the PTA reporting done? When reporting PTA, note the type and degree of hearing loss. Use the standardized symbols and frequency threshold tables, and add interpretation in simple terms of clinicians and patients. So what are the symbols used in PTA? You remember, like, red is for right, and since wrong cannot be right, cross is for left. So cross cannot be for right, cross has to be for left. So this is the mnemonic. Standardized symbols make PTA universal. And so also remember, O is for right, AC unmasked, and cross is for left, AC. and brackets are for bone conduction. Use masking symbols whenever it's needed. This allows quick interpretation and comparison across the test. Now, grading of hearing loss and speech banana curve. So there is something called as speech banana curve, which represents frequencies of common speech sounds. So mild loss may still hear speech. Moderate or severe loss significantly affects the communication. Grading is done in decibel ranges. Normal is 0 to 25 decibels. Mild is 26 to 40 decibel, and moderate is 41 to 55 decibel, and so on. Okay. Now, when we come to this we have the first PTA graph. When see in this is a graph of bilateral SNHL. So first we go towards the graph. In this graph we see that this is the right ear. Right ear is seen in red, and left ear is in blue. Now we see that both the ears are affected because both of them are below 25 decibel. Now so if left ear is worse than right, then mention it clearly. In so sensory neural hearing loss and auditory, in both the ears we see that bone conduction as well as air conduction, both of them are below 25 decibel, are reaching below 25 decibel. So both of them are being affected. But in the left ear, that is in blue, we see there is also an AB gap. So in left ear we have a severe high frequency mixed hearing loss, whereas in right ear we see that air conduction and bone conduction are within 10 decibels of each other. So right ear mein there is mild sensory neural hearing loss. Now we go to the next PTA. Here we see both AC and BC thresholds. Now yeah, so in this graph we see that both AC and BC in both the ears, that is left and right, are within 10 decibels of each other. So if BC thresholds appear better than AC by about 15 decibel, it's if the BC threshold it appears better than the air conduction by about 15 decibel, it's often an artifact. This you have to remember, especially in low frequency profound losses where bone conduction vibrations may be felt but not heard. Now, conductive hearing loss, in this in this graph we see that uh, what is conductive hearing loss? A hearing loss that is considered conductive when there is a difference of more than 10 decibel between AC and BC at any given frequency. Now, measuring the hearing thresholds is the significant AB gap. So, if the common in both the ears we can see that in left ear there is mild conductive hearing loss, and in right ear there is moderate conductive hearing loss. If we try to find the difference, so how do we test? We take an average of the 500, 1000 and 2000 hertz, the difference between air conduction and bone conduction. We take the average of these three frequencies. Now, common causes of conductive hearing loss include wax, otitis media, or any ossicular problem. When whichever is uh, which again that we have to mention which ear is worse clearly in this graph. That right is indicated like first, that right has moderate conductive hearing loss. So yeah. Again, this mixed hearing loss. What is mixed hearing loss? If both AC and BC thresholds are raised, but there is still a significant AB gap, we label it as mixed hearing loss. So in this, we see that in the left ear we have a significant AB gap, but the bone conduction also is below the 25 decibels. Also a hack while interpreting these PTA graphs is that BC, that is bone conduction, is always and always represented first in the graph. That is the one you see up in the on the upside is always bone conduction. So that is the hack, and the lower one is the air conduction. First you have to identify which ear it is, then the one showing above is always bone conduction, the one below is always air conduction line. Now, PTA, when we compare Meniere's disease versus presbycusis, in Meniere's disease typically shows a low frequency SNHL early on, whereas while in presbycusis, what you see is age-related loss that affects high frequencies first, and tracking this over time, it helps in diagnosis and management. Now, PTA in otosclerosis. What is otosclerosis? Basically, in this stapes is being stuck at the footplate of the stapes is ossified and it's stuck, so there is less movement. Otosclerosis is a classic cause of conductive hearing loss, and we look for a Carhart's notch, a dip at 2000 Hz in bone conduction threshold. So this isn't a true sensory neural dip, but a mechanical artifact from stapes fixation. But although we see this in BC threshold, mind you, it is a conductive hearing loss. It is a type of conductive type of hearing loss. Now, malingering in PTA. So not all patients that come for PTA are truthful. Functional hearing loss is real. And what are the clues? So we look for history. We look for the older reports, any older objective tests that may have been taken. If the patient is suppose like 25-30-year-old and has come suddenly for this PTA to get disability certificate and has not brought any older reports, then you have a strong suspicion that this disability certificate might be for some job or some seats they may want to apply for some government job. And you must clearly and very skillfully ask for such things in patients, and why are they performing such PTAs, and why are they coming for such disability certificate at this age. And so history doesn't match PTA, inconsistencies in the patient's story, and the repeated retests show variable results. Use objective tests like OAE or BERA to cross check. Now, yeah, this was a patient who was malingering for getting the disability certificate. Yeah, impedance audiometry. We come to impedance audiometry, also called as tympanometry. We now move into the domain of objective testing. Now, so PTA we saw was subjective. We come to objective testing. It is especially useful in kids and uncooperative patients, or when the cross checking subjective results. Now, tympanometry, it basically evaluates the middle ear function by varying the air pressure in the ear canal. It measures how much sound is reflected back, which tells us about the stiffness and the mobility of the tympanic membrane and the ossicles. Think of it as checking if the middle ear is a well-oiled machine, or if it has fluid, negative pressure, or ossicular fixation. Yeah. Now, tympanometry and its uses. This test helps differentiate between conductive and the sensory neural hearing loss. So it detects basically the otitis media with effusion and otosclerosis. It measures the middle ear pressure and eustachian tube function. It also useful in pre-op and post-op cases to evaluate the tympanic membrane and ossicular chain. Now, so what is the basic concept in tympanometry? Yeah, so this is how the tympanometry is performed. We have see, this is where how the first one is the where the sound is transmitted using using a using an instrument. 226 hertz is delivered, and then the last one, the third one, it creates the air pressure, and this the middle one, it records the vibration of the tympanic membrane. So the first one, it transmits the sound at some particular frequency. In this, it is 226 hertz. The middle probe is for measuring the vibration of the tympanic membrane, and the last one is the third one is for creating the air pressure changes. Now, see, there are certain tests, uh, for example, acoustic perilymphatic fistula test, and acoustic reflex and all. So we'll be going through that as well, uh, which are very much useful. So, what is the compliance? What is compliance? Compliance means the ease with which the tympanic membrane moves. So, increased compliance, where is it seen? Whenever the ossicular chain is discontinuous, when if there is no continuation. So, it may move as much as it can. The TM may move, and as well as whenever there is scarring, there is increased compliance. Then decreased compliance. When is the compliance decreased? Whenever there is otosclerosis or glue ear. So it's stuck. The TM is stuck. So there is no movement, not much movement. Normal compliance. When is it seen? Normal compliance often seen in eustachian tube dysfunction, or in without any ear fluid. Of course, if ear fluid is there, so then the compliance may decrease, as you know. Okay. What are the middle ear pressure abnormalities which are diagnostic? Yeah, so negative pressure can be seen in whenever there is any block in the eustachian tube or early otitis media. Then positive pressure early seen in early AOM, acute otitis media, or grommet insertion. Then flat or absent pressure whenever there is perforation, there will be absent pressure. The pressure is equalized, so there is absent pressure. Adhesions are there, then there is absent pressure, or even cerumen impaction is there. So interpret these findings in clinical context based on the patient to patient. Okay. Now we come to the types and shapes of tympanograms. So we use a classic classification, that is type A, AS, AD, and B, C. Okay. So what is type A? Type A is normal. Type ASC shows shallow compliance, means stiff TM that is seen in otosclerosis. And type AD means there is the TM is very much floppy. It moves here and there, and so there is a lot of movement of the TM. Where is it seen? It is seen in the ossicular chain discontinuity. Then type B is a flat TM, flat line, that is seen in OME, that is otitis media externa or perforation. Then if otitis media effusion or perforation. Then type C is negative pressure, ET dysfunction, seen in ET dysfunction always. Type deep compliance, type AD curve indicates floppy TM, and type B is we know that flat is because of the otitis media effusion. Then type C is because of the negative pressure, that is ET dysfunction. Now, electrocochleography. What is electrocochleography? ECOG measures cochlear and cranial nerve 8. So cranial nerve 8 responds to sound. Electrodes are placed near the tympanic membrane, and they basically record three things. First of all, the cochlear microphonics, which detects the cochlea and the eighth nerve, the submitting potential from the hair cells, action potentials from the auditory nerve. And this electrocochleography is very much useful in Meniere's disease. To look for in Meniere's disease, what we see is we look for SPAP ratio, and if it's more than 0.45, that indicates Meniere's. Okay. Now so in this slide we see that this electrocochleography can be transtympanic. That means that electrodes have been placed transtympanic or extratympanic. Now transtympanic is more accurate, but it is invasive. That means we are perforating the tympanic membrane, we are going through and through the tympanic membrane. Extratympanic is safer, but it is less sensitive. Now this is used in surgical monitoring and diagnosing auditory neuropathies. So we have something called as summating potential. This is a sum of various electrophysiological parameters, mainly positive and negative summating potential. And we have already seen that if SP by AP is more than 45%, that indicates Meniere's disease. Action potential is basically electrical activity obtained in the eighth nerve. It follows all or none phenomena. Okay. Now SPAP parameters. So yeah. So abnormal SPAP ratio, it often indicates endolymphatic hydrops. So if patient has vertigo, if any patient comes with vertigo plus low frequency hearing loss plus abnormal ECOG, so think Meniere's. Okay. Now so stimulus and inference from the ECOG. So for example, we see that cochlear microphonics is present and the action potential is absent. What does it mean? Cochlear microphonics is present, and but the action potential means the nerve is not able to conduct the signals received from the cochlea. So this indicates the cranial nerve 8th lesion. Now action potential may be present but cochlear microphonics is absent. This means that the cochlea is not functioning at its level itself. So action potential nerve is functioning, action potential is present, but cochlear microphonics is absent means there is lesion at the level of outer hair cells. Now, otoacoustic emission. We come to otoacoustic emission. This is another objective test like listening to the echo from the cochlea. Outer hair cells, these generate, which are present on the basilar membrane, these generate sounds that bounce back and are recorded with a tiny mic in the ear. And if OAs are present, cochlea is working, and absent OAs means either conductive or it may indicate sensory neural hearing loss. So this is basically used in screening newborns. So what are the uses? Uses of OAE? OAE is a game changer in neonatal screening basically. Identifying early, for example, identifying the early ototoxicity, then detecting noise-induced hearing loss, ruling out malingering fast because it is an objective test, then fast, non-invasive, and great for mass screening of many newborns. Okay, now types of OE, there are basically three types of OE. Spontaneous OE where there is no stimulus needed, transient evoked OE which is triggered by clicks, and distortion product OE which uses two tones basically, but this distortion DPOA is still at research level, not being used much. Now what are the advantages of OA over BERA? See, response of each region is seen in OA is separated from the OA signal after it emerges from ear by frequency analysis. Then OA level is similar to whatever the expected noise level is there in good surroundings. Now, what are the prerequisites for OA? To get valid OA, ear canal first of all must be very clear, then probe must seal well, then patient must be still and quiet. No middle ear pathology should be present. Also, OHCs must be functional. If there is wax, fluid or crying infant, OA will be falsely absent. Okay. Now, what are the results? So basically, when interpreting OA, remember that pass means present emissions means outer hair cells are working well. So suggests that normal hearing is present up to the level of cochlea. Now, refer means absent emissions might indicate sensory neural hearing loss or conductive loss. Now, unilateral versus bilateral response can detect asymmetry. Also, middle ear issues, for example, can block wax fluid, can block emissions even if the cochlea is fine. So don't jump to conclusions. Okay. Now, what are the conditions with abnormal OA but normal BERA? OA may be abnormal but BERA is normal. For example, tinnitus, ototoxicity, and noise-induced hearing loss and vestibular pathology. So in these patients might have subtle hearing deficit, but these are not yet reflected in neural transmission. Whereas there are cases wherein the OA is normal but there is abnormality in BERA. For example, in functional hearing loss, then ADHD, autism, auditory neuropathy, and IHC damage, but not inner hair cell damage, but not outer hair cell damage. Then auditory steady state response, ASSR. This is an objective frequency specific test. Frequency specific is very much important in case of ASSR. It is differentiated, unlike BERA which uses clicks. ASSR basically uses modulated pure tones to estimate the hearing threshold even in unresponsive or sleeping patients. So basically giving a instead of giving a broad light, we are giving a torch light and using modulated frequencies. If it overcomes BERA's limitation of being non-frequency specific, making it great for hearing aid fitting in infants. So how does it work? Pure tone sounds are modulated. Amplitude modulation is done 100%, frequency modulation is done 20%. So it's a frequency specific. Hearing threshold in all patients are found in irrespective of age, sex, mental state or degree of hearing loss. Now, ASSR procedure. So modulation, what does it do? It narrows down the spectral platter, that is main problem with the pure tone sounds, and hence in ASSR, very restricted area of the basilar membrane is stimulated. So this so it is basically like aiming a flashlight instead of floodlight. Now, how is the ASSR procedure step by step? First of all, patient preparation is done. Patient should be calm or sleeping. Electrodes are placed on the forehead and mastoid. Then stimulus is generated. Pure tones 500 Hz to 4000 Hz are modulated and then generated and modulated. Presentation, both ears are tested with different modulation frequencies, and then recording is done. Recording EEG captures the brain's phase lock response to each tone. And now ASSR procedure, threshold estimation, then thereafter threshold estimation is done. So if response is detected, hearing threshold is noted. If no response, increase the intensity, and thereafter the response is the threshold is detected. Then signal analysis, if a response is detected, it confirms the if a response is detected, it confirms the threshold. If not, then the intensity is increased. So BERA. Now we come to the most detailed test, that is BERA. It measures neural responses to sound within the first 10 milliseconds. Now the sound travels from the cochlea to the brainstem, passing through the cranial nerve 8, cochlear nucleus, superior olivary complex, lateral lemniscus, inferior corticulus, etc. Think of it like a relay race. Each wave is a baton exchange. So, sedation for BERA. In infants or uncooperative patients, sedation may be needed. So, the drug used most commonly is pedicloral, that is chloral hydrate derivative, and action is it enhances the GABA A, causing CNS depression. So, dose is 50 to 75 milligrams per kg orally, and the onset is 30 to 60 minutes. So, always monitor vitals and use trained personnel for administering this sedation. So response timing, short latency responses within 10 milliseconds BERA, middle latency response 10 to 15 milliseconds, and late latency response takes more than 50 milliseconds, or cortical late latency response or cortical potential. So each gives us information from different levels of the auditory pathway. This this is how the BERA is being conducted. BERA input and electrode placement. So stimulus broadband click 100 microseconds, 40 to 60 decibel intensity is present, repeated 2000 to 4000 times. Electrodes are placed at active electrode is placed at the vertex, reference electrode is placed on the ipsilateral earlobe, whichever is measured, then ground electrode is placed on the forehead. This setup ensures a high signal to noise ratio. Waves in BERA. So BERA generates 7 waves and each is from a specific relay station. Wave 5 is the most robust and clinically significant. It correlates to the inferior colliculus, and this is the last to disappear in hearing loss. So the latency of wave 5 is around 5.6 milliseconds in normal hearing. So waves latency and interpretation. Wave 1, it lasts for 1.65 milliseconds and it is from the cochlear nerve, originates from the cochlear nerve. And wave 3, so the most important are the wave 1, wave 3 and wave 5. Wave 3 is lasts for around 3.8 milliseconds and originates from the cochlear nucleus or the superior olivary nucleus. Wave 5 originates from the inferior colliculus. The interpeak latencies between 1 to 3, 3 to 5 and 1 to 5 are of very much help in diagnosing the site of lesion, whether it is retrocochlear or cochlear. BERA in retrocochlear dysfunction. What are the key findings? First of all, there is prolonged wave 1 to 5 latency, abnormal amplitude ratios, distorted waveforms, interpeak intervals with more than 4.6 milliseconds, and this is seen in acoustic neuroma, and that is retrocochlear, and multiple sclerosis or brainstem lesions. Now, Bera in cochlear pathology, what is seen? Cochlear loss shows increased threshold, especially at high frequencies. So this threshold is increased. There is poor wave morphology, and wave 1 and sometimes 3 may be absent. So both interneural latency difference is usually normal, but yeah, mind you, the interneural latency difference is usually normal, unlike in retrocochlear where the latency is increased, or in cochlear it may be normal or it may even be slightly reduced. Now, non-clinical factors affecting BERA. So the interpretation errors can be due to high stimulus rate, then polarity of clicks, then gender. Female responses are often faster, then neonates versus adults, electrode placement or poor skin contact. Always repeat. So we have to always repeat in doubt. So uses of BERA. So BERA is very much invaluable for threshold estimation in neonates, identifying the cochlear versus retrocochlear deafness, then ICU monitoring, confirming brain death, diagnosing central auditory disorders, evaluating the maturation of auditory pathways, etc. Okay. Now, what are the pros and cons of BERA? So, using BERA has its own advantages. It's an objective test, it is non invasive, it is ideal for newborns and malingering cases, helps detect the central lesions. What are the disadvantages? It is expensive, it is time consuming, then not frequency specific, prone to artifacts and interpretation errors. So I wrap up with gratitude and an acknowledgement to Dr. Praveen Kumar sir, my consultant for clinical insights, and audiologist Ankur Saini and Ramesh Saini for the technical support in this making this slide PPT presentation. So thank you everyone, and thank you all the listeners.